Just in time.
We are live.
We're live. Senate Appropriations. It's February 25th. We're hearing FY26 budget requests. And today, or right now, it's DIVA. And I'll let you guys introduce yourself for the record. I assume you don't need introductions from us. Do you know everybody here? We'll do. Yeah.
Terrible.
Should give me that.
Everyone else.
Yeah. Franklin County.
And Elbert.
Part of Grandale.
But I have lecture.
This is true.
Okay. And who are you?
Sean Groves, DIVA Commissioner.
And I'm Stephanie Barrett. I'm the financial director for DIVA.
And we have Sandy.
Sandy Hoffman, Deputy Commissioner, DIVA.
Great, welcome. All right, I assume we have a presentation.
We do have a short, we have a long presentation. We have a short highlight reel of our accomplishments from last year, and then we'll let Stephanie get into the ups and downs for that. And I do apologize, we do have a hard stop at 3:30.
Okay. We're not going to hopefully be here that long. My Senator Norris has lots of questions.
No, I just want to kind of go over our 2024 kind of key achievements that we made significant progress towards our mission for the department. We recently completed the post-pandemic Medicaid renewal restart period with a 75% enrollment retention rate. We completed annual open enrollment for qualified health care coverage for 2025 with record enrollment numbers, also utilizing federal funding available to save Vermonters thousands of dollars on insurance premiums. We remain committed to value-based payment priorities, resulting in predictable, and we use that for predictable and flexibility for payments for providers. And so instead of providers solely for the number of services that they deliver, we use it to link payment to quality. And we've been doing that since 2014. Our largest initiative is the Vermont Medicaid Next Generation Accountable Care Organization. And we've seen the increase in payments rise. Last year, reported at $1.2 billion, going alternately through those models, and that represents about 76% of the Medicaid spend. And then in 2024, we executed a contract with UVM Health Network to expand participation in the comprehensive pain program. We also are aiming to kind of streamline our business operations by harnessing an adaptable cutting-edge information technology. We are involved in significant IT initiatives through the Medicaid and Management Information System program and the Integrated Eligibility Enrollment Program. With the Integrated Eligibility Program, we are currently in RFP with our kind of plan for design and development and implementation to go from 2026 to 2030. We've also continued to be invested in continuous improvement as part of our work, maintaining a comprehensive risk assessment process for the Medicaid program. We've also seen the total number of PA authorizations decline last year, but that's largely due to removing those PAs as barriers, changes to the utilization review and process, such as for eating disorder, that really reduced the unnecessary barriers for treatment. We continue to be invested in our staff. We are committed to them. We have a 83% effective communication rate. We have 86% of our staff agree that they're doing meaningful work. In terms of required reporting, Act 97 of 2024 directed the department to develop their reimbursement methodology to examine the potential impact of adding coverage for DIVA services. And we constructed several reimbursement methodologies that looked at including services before, during, and after labor delivery, which included the flexibility of billing increments. That totaled about, looking at a rate around the max rate of 2,100. There's more information we can send the committee if they're interested, the last sort of kind of reporting requirement is on Act 157, in which we provided a physical estimate, for ambulance services. If rates were adjusted to be equal to Medicare, we found that annualized fiscal impact would increase to $520,000. And we have not updated the ambulance fee schedule in January. The last effective update was July of last year, and only increased the reimbursement for the treatment of the non-transfer code.
Okay,
But
that was rapid. There's a lot of information.
I told you this sort of back.
Any questions on the highlight reel?
No.
But that's different than what you have in,
That's it, that's our annual report of status of.
right, but that's different than what's on the budget narrative document.
Yeah, the budget narrative and the ups and downs go together. You know, if you want to go, we'll go up through the ups and downs, but I'll sort of cross-reference to the budget narrative as well, where we sort of combine. We have 4 appropriations in DIVA, and some of the pieces, particularly in the program budget, cross all 3 program appropriations. So that's, we combine them in the narrative that we'll go through, and start with our administration budget, which is section 306, E306. And if you're looking at the ups and downs and you go to the bottom line, it's $182.2 million. It's very similar to the total that you passed last year, but there are lots of moving pieces in the admin budget. And there are you know, some significant ups, particularly in our staffing budget, which are the salary and the impact on fringe benefits from the rollout of Pay Act. That's the majority of what you see moving up in our staffing budget. We do have one new item in our staffing budget, and that is funding for 8 BCCI case management positions associated with the Justice Reentry Initiative. And that will start mid-year. The actual initiative will start mid-year, January 26th, but we need to start to bring the staff on for that sooner than that in preparation for the start of that initiative. And so you see that in a line item in our budget of, in total, $924,000. All the other line items related to staff and benefits total about $5.6 million gross dollars, and about $2.5 million in general fund.
Is this reentry out of corrections?
Out of corrections. So folks getting enrolled in Medicaid before they are released in 60 days or 90 days? 90 days before they are released, they're enrolled in Medicaid, and it comes with a, you know, if they're on MAT, supply of MAT, leaving the facility, etc. We also have a few in our personal service budget contract adjustments. One is net neutral. Some of these are going to seem very similar to the items that we discussed during the budget adjustment presentation, because this budget is always in comparison to the budget we passed last year. So in order to bring things up to date, they're very much similar. It's just annualized versus the mid-year adjustment level. So we have legal aid moving into our admin budget out of our program budget to, on a gross basis, a net neutral move. No increase to legal aid. It's simply having to be put in the right location.
And this is legal aid work on everything,
This is particular, I think, to eligibility related pieces. There's a significant amount of funding that goes to legal aid out of the agency. This is a particular piece.
In the new reentry positions, is that program that somebody else created, but it's coming through your budget, or is it?
So it's the Vermont Care Coordination Initiative unit. So these are the same. These are the folks that handle complicated case management for folks that we have.
Are we expanding it, or is it just the whole thing, or just like you just 8 more?
The eight more is the expansion.
So we had some number.
Yeah, we have a group that We can get you the details on what the baseline is if you'd like.
No, that's, okay, I get it.
But these are not the skilled nursing or the nurses like we are when we have a complicated case. These are case management. They're slightly,
But you need it because there's just more people in the program.
we have to do the case management for those folks in corrections that are coming back into the community.
And you have more of them re-entering into the community than we did before, so you need more coordinators. Is that?
We weren't necessarily doing the case management.
Oh.
No, it's a new initiative that's
It is.
allowed under the waiver. I'm sorry, I didn't explain that.
Okay.
And that, you know, the approval for that came last year, and it's taken time to stand that up and, knowing that the turn-on deadline or date that we have is January 2026. And then we have, across the bottom of the personal service line, several adjustments to existing contracts that are, you see in our budget. And together, those total $1.7 million, 720 of general fund. Some of them are due to a change in the way we account for different funding sources. So they're not actually netting up in the contract. They're us identifying, like we talked about in budget adjustment, the best way to match and allocate under what are called advanced planning documents for some of our IT projects.
Okay.
And then we have some operating changes. Most of these are, you see from other departments, they're mostly related to the internal service funds, the overhead costs of operating the departments. We do have in DEVA what's called an AVS MOU, because we have several large IT projects that we don't hold the contract for, but we hold the funding for. And so that ends up in our operating budget. And so you see very similar sum adjustments to those contracts in our operating budget. And then you also see that we need to have equipment for the 8 new BCCI positions. So do folks want to go more in depth line by line on the
Probably not.
budget?
I'm guessing not, no.
In total, there's one item, we talked about this in budget adjustment as well, and that's a downward adjustment in our federal funds spending authority line in state fiscal year 26. And this is just right sizing what has been a sort of an anecdote.
It's the $8 million.
The $8 million. It doesn't change anything that it says we are over appropriated our federal spending authority in our operating line. That stemmed back from a few years ago when a one-time item, the general fund was one time and the federal funds got embedded in the base over and over again. And so we're just correcting that. We're maybe continuing to correct that, but it's not an up or down to any cost of the overhead of the department. It's simply making sure that we're not over appropriated in a line item. So we'll move on to the program budget next. And so the program budget, the main program budget is section 307. That's our global commitment budget. The only funding source, if you're looking at the ups and downs in that line item, is the global commitment. So we get the matched up dollar, and what you just talked about with the Secretary's office and the mixing bowl. Tracy holds her office holds the general fund and the federal fund spending authority, and we and other departments that spend global commitment monies are spending it out of that funding source. So as you've probably heard from others, that's a duplication in the appropriation structure of the state. We get appropriated the mix up the dollar. Tracy also gets appropriated the two component pieces. So what matters is that, in fiscally for the general fund is what is the match on all this. And so the first item in our ups and downs, both in section 307 and in our other two sections, are what we call caseload and utilization adjustments. And that's the result of the consensus process where DIVA, the central office staff, finance and management staff, and JFO staff come together and basically in the late summer and through the fall, we need to update the forecast for the caseload in Medicaid, and in DIVA's case, the cost per case, the expenditure per case. And so we saw a significant adjustment in the budget adjustment. And we're rolling out and still seeing that adjustment needs to be done again from 25 to 26, because we are comparing to where we were last May, not comparing to where we are for budget adjustment.
And how, this 46 million NVA, does that go back years, like, or is this?
No, that's just, that was,
Is that common, like this dollar amount?
no, this is a large adjustment. Although Medicaid, things can be pretty large,
Right.
particularly in DIVA's nearly $1 billion single appropriation line.
Yeah.
But it was a larger than expected adjustment. So we came last year and we said, take $50 million away from us. We think we're on a track, but that was premature because we were still mid unwinding and we were looking at cost per case that were impacted by still a higher caseload. And as we closed the year and we came through the first quarter and then the second quarter of the year, we could see that our trend line was off. And that's why you saw that significant adjustment in the caseload and utilization in the budget adjustment process, and you're seeing it here. So it's $46 million in this line item. It's a little bit less in our state only and our non-waiver. Those are, specific populations that are paid for in those. So in total, across all three appropriations, it's $51 million. And 21.
Is it mostly utilization or is it both?
It's all
caseload?
utilization. Our caseload's been spot on. We've been very good about projecting our caseload. It is the cost per case that we have struggled with over the past year.
Senator Lyons has a question.
Well, I'm moving down. I'm waiting till you go
Oh.
down the line items and then I'll ask my questions. I got ahead. I should.
Okay.
That's not bad for it.
And if you're following our narrative at all, I do have a little blurb in there, just like the secretary said. The biggest risk to our appropriation, our program appropriation, first is the unknowns at the federal level, and then also, if we have modest, even small modest percentages off on our trend, that's a lot in DIVA. And the rebate area, the pharmacy rebate area, is another area that's always challenging for us. So we'll talk a little bit more as we go along. So in total, across all three appropriations, caseload and utilization, all driven by utilization side of the equation. And I don't mean that it means that we can get the cost per case right. We don't have as much granularity as we'd like about, how much of that is driven by the fact that we got it wrong in terms of the unwinding versus how much is that driven by out in the field, changing trends. Those are mixed together in this total for us. But that's the total for that. The next item is the Medicare Savings Plan expansion that you enacted last year in the budget bill that you passed. So that is scheduled, or should be in, the date you gave was January 1st, 2026. So this is a partial year estimate of the cost of that expansion. It's very aligned with the estimate that we gave you last year. We did a little, obviously, months go by, we update to see if it's still the same. It's not identical, but it's very similar to, internally, our analysis showed that our estimates were coming in very similar. So this is a 5-month estimate. It will have to be annualized when we build the 27 budget. So you'll see it again next year, is what I'm saying.
Is there any benefit to moving Quimby up to 150%? What is it? Doesn't it align better?
So that would, so what you enacted was a Quimby at 145%,
Yeah.
subsuming SLIMB, and directing us to do the qualified individuals at the highest amount that would be allowed based on what we were seeing, basically what New York had enacted. If Quimby was set at 150% of the poverty level, it would align with B Farm one break and with the low income subsidy, which is a federal subsidy. So that's that 5%, they're misaligned. We still, so that's the difference that I think you're looking at. And the House Healthcare Committee did ask us about that as well, and we sent them a memo on it last week.
I'll let them ask you first. I do have, the other question is on the line above, the psychiatric residential treatment facility.
Sure.
15 beds. Is that in the narrative?
That is in the narrative. It is item number 7 in the narrative.
Yeah.
And that is annualizing. When you pass the 25 budget, we included a partial year amount. That program is imminent. The negotiations have been going on, so we expect to have that program stood up fairly soon. What this amount in the 26 budget is taking the base amount that you appropriated for us right now for the partial year and annualizing that. Because when we get to the full year of 26, starting in July, we expect to have a full year cost for that program. So this is what you're seeing in that line item is only a partial year because it's the add-on to annualize what was provided in this current year, which we expect to start spending in the last part of the year. Some folks are looking at the ups and downs. We do have a handful of areas where we have to make rate changes, and those are similar to what we talked about in the budget adjustment. The hospice rate has to be at a floor, so that's annualizing that rate. We have what's called the Medicare Economic Index for our FQHCs and our rural health clinics, and so this is annualizing for FY26 the index that was applied in February for, you saw a partial year of it in the budget adjustment. And then we also have a small amount of expenditure for the direct care workers that have a collective bargaining unit. The majority of the impact of that you'll see in Dale's budget if you haven't already, but we do pay for, particularly for some kids, the cost of direct care. And so that bargaining unit comes with an increase in cost, and that's what you see on the line item for the tax me line for us. We talked about the Medicare savings plan. We talked about the psychiatric residential treatment facility. The Secretary's office spoke about the GME increase. This is an increase in spending authority in the global commitment. This is the one that doesn't come with a state match burden on the general fund because the university takes that out and provides that match. But it is a calculation by which we can increase that expenditure to the medical center. And so that's what you see is that $7.2 million, which increases to a total of $65.6 million. None of the match on that comes from the general fund. That all comes from the university.
Does that university donation count as a charitable donation, do you know, or is it a grant?
You know, 7 million is the match to get the 65 million.
No, 7 million is the increase over last year.
Yeah.
So we're going from 58 to 65 million. None of the 65 million is a general fund match. It's all provided by the university. And I can't answer the question of, I don't think it's counted as a charitable organization.
It's not charitable, it has to be a grant.
Yeah.
Does it come out of?
Oh, it's a government, yeah.
It's a what?
It's considered an intergovernmental transfer.
Intergovernmental transfer. Okay, I gotta remember that. Bill, that's good.
Okay.
And then we have a couple net neutral moves. You see it down for the Blueprint Spoke and the Pregnancy Intention Initiative. Those are not cuts. You'll see them as an up in the next section of the budget. They need to be accounted for as an investment, and we had them in the regular program.
Okay.
And so our GC investments are in our state-only line item, which is, section 309. So in section 309, we talked briefly about the caseload and utilization here. This is primarily related to the IHIP program, the Immigrant Health Program, and the B-Farm program that is state only. That's the change that you see for caseload and utilization. Just above that, you see a negative 1.5. That's our cost sharing program, which is a state only funded program. We talked about this during the budget adjustment. In the current plan year that started January 25, we have far less folks. We did something called gold mapping to have folks who are buying their insurance on the exchange, but are in an income level where we support them, either with premium assistance or cost sharing reduction, buying a better product to maximize the tax credits. And that means that the cost sharing program is tied to silver plans. We have far less people in silver plans. That's why you see the reduction. This is annualizing the reduction that we took a partial year of in the BAA. Obviously, what the landscape for the exchange looks like in January 2026 is has a question mark in terms of the tax credits around it.
Okay, yeah.
And then we have also a clawback increase in our state only. Clawback is stretching back almost 20 years to the turn on of Part D, where the way the federal government partially funded the Part D Medicare benefit was by clawing back savings that the states would experience in their Medicaid program as a result of that expansion. And so they calculate based on pharmacy costs and caseload what the states owe. And we get information on that from FFIS, and we make an estimate of what we have to pay them every year. And this
What's
is
the total that you pay? It's a 1.4 increase.
it's a 1.4 increase on, I can't remember, I think it's in another sheet. Clawback total is $47 million.
Wow.
Senator Watson?
Just so I can have a little bit of the background here, this is a structural clawback as opposed to there's a definite, like, finite amount of money that is being ultimately clawed back. It is an ongoing, because of the structure.
It is an ongoing structural calculation by the federal government based on our Medicaid population and drug costs. And I don't, that's the extent of my depth on the formula. FFIS puts out a brief every year on when that calculation is completed and what the estimated impact state by state is. And they do, I just can't recall, but they do a pretty good job of describing the nature of it. If you're interested, we can get that for you.
It's interesting, it's also kind of a bummer, but
Yeah.
But they are saving.
Well, so prior to Part D, which is the part of the Medicare benefit that covers drugs for folks, we were paying and Medicaid for people in certain income levels and for our dual population. So once our dual population we buy them into Medicare. Once they had that benefit, we had savings on the pharmacy side, and that was the juicy target for funding it.
Gotcha.
Okay.
Without it, people would be in trouble. Paying a lot of money for drugs. More money.
People don't remember that prior to Part D.
I remember that part.
Medicare was
I
not
remember
covered
it was
drug
like
coverage.
falling off a cliff for a lot of people.
But to be clear, this is being clawed back by the federal.
Yes, I've heard
Yeah.
it referred to as a reverse block grant from the states to the federal government. But it is the structure of how the program is set up, and we get a bill every quarter. saying, you owe us this, and it's a bill that we pay entirely in general fund dollars, because they're estimating the state savings to the state.
Okay, all right, thank you.
And then the last thing you see in section 309 is the actual, where the blueprint spoke and the pregnancy intent needed to move down to. So that is the total in 309. And we'll take a look at the last section of our budget, which is our non-waiver budget. And we have a caseload and utilization adjustment there. That is pretty much entirely the CHIP program. So that's the program to us that looks seamless in Dr. Dinosaur. But it's the program that came in the mid-90s to cover kids at a slightly higher income level. A portion of the MSP expansion is the qualified individuals. That's 100% federally funded. So we carry the cost for qualified individuals in our non-waiver line item. We carry the cost for most of our VFOM program and our state only, and that was a negative to the, there's a savings in there because of the expansion needed for MSP. And then the majority of the MSP expansion is in our global
NFP,
NMSP, the Medicare Savings Plan, the expansion that you did.
thank you.
It just
I thought I
ends up,
heard N and I.
no, I'm sorry about that.
MM.
But the fact that the increase to that program that will turn on actually doesn't just live in one line item for us. It impacts all three line items because of the nature of the program and how it saves money in one area.
So the applications for that, do we have any understanding of how many people are actually taking advantage of that program?
We, right now it's simply an estimate because it's a January 26th turn on. So the question
so we still don't know.
That may become more clear in the late summer and fall as we see what that looks like.
What is the pregnancy intention initiative?
So that is the new name for something that used to be called the Women's Health Service Program, Women's Health Initiative. And I think we pay higher cost for, I think we pay cost reimbursement for LARC, and I can get you the details on it. But it's not a new initiative. It's a new name for a pre-existing initiative. And it's an investment for us. It's not a regular Medicaid expenditure. And that's why it's moving.
Right, okay.
And I think that covers everything in all our line items. The last item to talk about is a one-time item included in the governor's recommend. That is the bridge funding for the 26 plan year, for calendar 26. So it's in our state fiscal year 26 budget. Since we will not have the ACO and a successor to the ACO, which at the moment is ahead anticipation, 26 will not have an ability to have the Medicare money that had flowed through the ACO to the blueprint and to the SASH programs. And so the state is including a $10.8 million proposed appropriation to bridge that gap to 26.
Because the Fed doesn't start till 26.
To January 27. So this would cover those two line items. Just another point to make about the ACO not being in operation in plan year 26 is that the total budget of care that had and costs that had flowed through the ACO from our budget is still there in our base budget. So those costs, the fact that the ACO is not there doesn't mean that we agreed allocated anything about the base of funding that had flowed through.
I assume there's some savings from the ACO going away, or was it mostly just passing it through there?
Not to there's no savings to our budget. Those were all passed through. The ACO funding functionally and primary, I think, dues of the members. Other than funding, so, you know, I don't know for sure, but we were not paying any sort of cost to administer, you know, any sort of cost associated with administration of the ACO.
Caroline?
So in terms of the ACO, one of the things that they do have very good system for doing data analysis for quality metric analysis. And I don't know how much you have been involved in that, if at all. I know it's all at the ACO. I went and looked at what they were doing. It's kind of neat.
So I have not been involved in that.
Yeah.
I know, you know, if you wanted to have a conversation with Alicia Cooper, our Director of Managed Care, I think
We
she
got
might
it
be-
coming in.
Okay, so you
Yeah.
might, you're ahead of the game.
I think tomorrow, as a matter of fact. That's good. Good, thank you.
Jenny, any other questions for the commissioner stuff? Okay. $1 per question, you're doing very well.
Not a bad place to spend a rainy afternoon.
Well, thank you. If there's no questions,